Ghent in Belgium. So we inaugurated it in May 2007, but it's only in August of the same year that we're able to start the services being initiated, and we'll be able to get a presentation that will talk more in terms of what you've seen over the years. So what do we provide at the GBVRC? We provide medical, psychosocial, legal, and also referral. In terms of the medical, one of the things we do is the issue of treatment of injuries, first aid and all that. Issues of if someone presents and maybe has life-threatening injuries that they need to be taken to the theater, that is provided at that level. Post-exposure prophylaxis to prevent HIV transmission is provided. ECPs, STIs, treatment is also given. Then at the same time, we also collect specimen for both the medical and forensic purposes. And this also includes documentation which involves the filling in of the post-rape care form. And also we have the government doctor who eventually transcribes the PRC form into a P3 form. In terms of the psychosocial support, we provide trauma counseling for the survivor. And from our experience, we've come to learn that, especially in instances whereby the survivor is a child, the trauma may be more profound in the guardian or the parent. So we also provide this as another service in terms of the counseling. Then also there's the issue of HIV counseling and testing because of issues of PEP. Then we have adherence counseling for people who test HIV positive. In terms of the legal component, what we do is we provide that referral to the police sector so that you can have an easy transition from the health sector into the justice system. Then court preparation for the survivors just so that they can know what to expect when they present their cases to the criminal justice system. And in a few cases, we watch brief in court just to ensure that procedure is complied with and everything goes as is required. Then we also provide the specialized referrals for specific cases depending on the needs of each and every case. So I say we provide the services 24 hours, and this is basically because we have a very close collaboration between the center and the casualty. So the center itself is open Mondays to Fridays between 8 and 5 p.m. But beyond these hours, survivors are seen at the casualty. In terms of staffing, we have, for the medical care, we have 3 reproductive health clinical nurses from the obstetric department who are on call whenever a survivor comes in. That's when they come on board. We have a nurse, 2 trauma counselors, 1 legal officer. Then, of course, there's the collaboration with the various departments within the hospital, the lab, the pharmacy, and all that, so that you can provide the other care. So, in terms of ongoing activities, we have the services that we are providing, the medical, psychosocial, and the legal trainings. And we've done a number of trainings for healthcare providers and also paralegals, and a few interdisciplinary trainings that focused on the forensic management that entailed a whole cadre of people from healthcare providers, police, prosecutors, magistrates, and all that. We have community awareness programs through our paralegal program, research, and one of them I know there's a book that has been circulated a few minutes back on facing violence, which is a documentation of the real-life experiences of survivors of sexual violence. At the moment, the research that you're carrying out is one in which you're trying to do a follow-up on the legal outcomes of the cases that are provided with services at the facility. Then we also have the community outreach component as the other one. So the gist, now maybe to go right into the gist of my presentation, we know the different models that we have when it comes to issues of caring for survivors of sexual and gender-based violence. We have those models like ours that are in a public facility. Then we have those that are in private facilities, either a house that has been set aside for survivors to come in and access services, or those that have are within private hospitals. So my mission today is to talk about the model that is within a public hospital. So we all know how it goes with the private settings. It has its strengths, it has its weaknesses. And I know the most vivid example, the best example that we can use is the Zuzela model that is in South Africa, which is a facility that has been set aside and survivors are able to be attended to. And we know that the strength for the private facilities, one, they have control over the quality of the services that they can provide to the survivor. Then, of course, they have specialized and dedicated staff who are really motivated to be able to carry out their work. But then again, in the same vein, we have a few challenges with the private model. One is the selected public attending because of issues of costs and all that. So you find that when it's private, not many people will be able to attend that. There's the issue of sustainability, because to be able to have a full 24-hour shift, you'll need at a minimum at least 5 staff to be able to take into account issues of shifts and night shift and getting people who are on leave. Then, of course, there's the issue of ownership by the community as a challenge. So in terms of the public hospital model, what we have in terms of strengths, and this is based on the model that we are using in Mombasa. One, we are able to guarantee at least 24/7 access, and this is through the casualty. What we have is that between 8 to 5, they are seen at the GPVRC, but beyond these hours, they'll still be able to access the services as any other person who's accessing the services within the hospital. Then again, we realize that being a public hospital, the majority of the people who access this service are those people who are almost at the lower end of the socio-economic ladder. So you find that these are people who present as needing these services more than anyone else. Their options are basically limited. Then again, the other strength is that being that it is within a public facility, issues of space do not become so big because we already have it as an institution in a public facility. All you need is maybe convert a few rooms and all that without incurring extra costs in terms of maybe renting extra space and all that. Then again, there's the issue of the availability of other services within the hospital. Once all these other services have been provided, we can still be able to refer the survivors for other services like the comprehensive care centers, the pharmacy, the lab, and others. In terms of challenges, we've had a number of them, and one is the issue of staffing. We all know that we are operating in a resource-poor setting, and if you go to our public hospitals, the staff and patient ratio is not enough. So that is one of the biggest challenges. You find that you will find it's only one medical officer maybe in the casualty addressing all other cases. So we have that as an issue, issues of numbers. Then of course, as in all sectors, there's the issue of knowledge gap. So over and over we've had organizations, including ourselves, who conducted training for staff. But in terms of the staff turnover and transfers and all that, you come back 3 to 6 months later and you have a new group. So it comes up with that challenges in terms of you train people, but within a short period of time, the turnover is so high. Then of course there's the issue of motivation, which I think has been running throughout the discussion throughout this week. Being that there's still that need to do something extra so that there's a lot of ownership and the staff are able to take it up as one of them, of their own. Then also there's the issue of the commitment of the hierarchy. Still SGBV, it's only until recently that it was acknowledged as a national issue. And it's slowly now being taken in as a serious public health, human rights, and also developmental issue. So we find that at times, even in terms of commitment, even if you look at our budgeting, it is not being taken in as something that actually needs to be given priority. Then again, issues of supplies is a big problem. We've always, enough times there are stockouts and all that, which also poses a challenge in its own. Waiting time, a big challenge, especially if it's for hours when the survivors are being seen at casualty. One MO addressing all other cases. So at times, people may stay in longer than is necessary. Then of course there's the issue of coordination in the GPV sector, generally, in the intersectoral collaboration and also within the facility itself. How do you coordinate with the pharmacy and casualty and social services and the CCC and the mortuary and all that, so that as cases present, you're able to know what is going on and be able to come up with strategies to address the same. In terms of opportunities, what are some of the things that we see we can do? One, this provides an opportunity for us to integrate other services within this existing model. For instance, for us, we've been able to do the medical, the psychosocial, and the legal support in this. And at the same time, we are also trying to reach out to the community so that it's not just about the healthcare facility, but also are we reaching out to the community? Are they understanding what is going on and the challenges? And are they accessing these services? Then again, another opportunity, we believe that there can be sustainability, so long as there is ownership by the health community as an issue of priority. Then another opportunity is community outreach, because based on what we see at the facility, we are able to see trends and patterns and able to come out and get out more and tell the community this is what is going on and this is where we should be able to focus our priorities. Then, of course, the other opportunity that I've talked about is that there is an opportunity for access by a community that needs it the most. They have very limited resources, they have very limited options, and when they present in a public facility, then they are able to get that particular service. The other opportunities in terms of setting up all these different social safety nets like survivor support groups, volunteer networks, and paralegal networks. And these we've been able to do through one of our programs. So far we've been able to train at least 50 paralegals who are providing that vital link with the community and have helped us in terms of strengthening the referral network. Then, of course, in terms of data, this can help us in terms of being able to collect data, to document terms, and this can help in terms of planning and budgeting. Then the other opportunity is in terms of the increased implementation of the Sexual Offences Act, which has come out quite strongly on some of these issues. In terms of threats, one, we find that being that the reliance is placed so much on the private-public partnerships. Most of the times it's donors who come on board and they want to work with the public, with the hospitals. So what happens then when the donors decide that their priority has changed or they want to get out? It may come as a problem. Then there's also the issue of sustainability, again being that it's mainly a PPP. What happens when, for instance, again, priorities change? Are our hospitals, our public facilities ready to take it up and run with it as it is? Quality of services, again, given the different slides I talked about when I was talking about when I was speaking previously. Then again, there's the availability of referral services. We may give so much, but when we want to now refer the survivor to the next step, are these services available? For instance, shelters, issues of child counseling and all that, are they available? So this comes in as a threat. Then of course is the issue of collaboration with other sectors like the police and all that. This has been one of the challenges when it comes to issues of forensic management. So much has been done within the facility, but at times because of poor collaboration between these two sectors, then it poses other challenges when it comes now to the issues of access to justice. So in conclusion, and based on our findings, we say that having a post-rape care that is situated next to the casualty of a public hospital increases access to services of a population that needs it the most. Then again, we say that this model is sustainable, but only if there is ownership by the health community. Then it also provides an opportunity for the integration of other services and also community ownership. Then again, we say that with regard to the legal component, if we integrate the legal component within a healthcare facility, it enhances access to information on issues of rights. For instance, groups that have customarily been criminalized and this has acted as a barrier to access to services. And again, it helps to strengthen the referrals to the justice system. And yeah, these are the various groups that have supported us over the years that we'd like to acknowledge the support. Thank you.